Hey everybody, thanks for joining our Oncology Data Advisor podcast today. My name is Waqas Haque and I'm a third year internal medicine resident at NYU and I'll be starting oncology fellowship at U Chicago. Today we'll be discussing gallbladder and bile duct cancer awareness month. This is a condition that affects 5 to 8,000 people annually, and even though it's rare, it can be very devastating for patients. I recall at my inpatient oncology service having to take care of patients with late stage complications of biliary cancer, both intrahepatic and extrahepatic, and also patients with gallbladder cancer, having to track the biliary labs every day, having difficult conversations about goals of care and code status, and really trying to find ways to promote comfort for people in their last moments. I'll let Dr. Hadfield introduce himself, and if you want to tell me a little about your experiences in treating these cancers, that'll be great, Matt.
Yeah, sure. I'm Matt Hadfield. I'm a third year medical oncology fellow at Brown University in the Legarreta Cancer Center in Providence, Rhode Island. Cholangiocarcinoma is a very tough cancer to treat. So, I've had multiple patients throughout my fellowship training who presented to the hospital, and Waqas, I'm sure you've experienced this as well. Patients who have cholangiocarcinoma can often present with, hepatobiliary disease. So, like obstructive patterns when they present, they can be very, very sick, and sometimes they can be so sick at presentation that they can be difficult to treat with standard treatments. I think thankfully over the last several years we've had some advancements in the treatment of cholangiocarcinoma, particularly the advent of using immune checkpoint inhibitors in combination with chemotherapy, which has improved overall survival. And we've started to use more whole exome sequencing, identifying different driver mutations such as BRAF and TRK. And HER2 IHC expression is something that's become very relevant in the most recent years across a lot of solid tumors, but particularly cholangiocarcinoma. So it's a very difficult patient population to treat, unfortunately. And, we really do need more novel therapeutic approaches to better prolong survival in this patient population.
Yeah, thanks for sharing that, Dr. Hadfield. One thing I sort of want to talk about is that I know you recently published a study and review on cholangiocarcinoma in the International Journal of Molecular Sciences. Can you just tell me a sort of interesting point or something you learned that was surprising from your experience with that research?
Yeah, I think some of the things that we've seen in cholangiocarcinoma haven't matched up with other malignancies. For instance, there's tissue agnostic approval for BRAF inhibitors, now BRAF MEK, and all solid tumors expressing BRAF V600E mutations. But if you look at the prospective data in cholangiocarcinoma, there's very few patients who have BRAF V600E mutations. But of those that do, they don't seem to respond as well as other tumors, particularly lung or obviously melanoma, where BRAF MEK is second line standard of care therapy with really high response rates and durable responses. So I think that's an interesting, part of the pathophysiology of how those mutations work in cholangio versus other cancers. I also think, some of that may be, again, like people with hepatobiliary cancers, they tend to be very sick and very hard to treat. They have a lower performance status secondary to their malignancy. So treating them successfully and keeping them on therapy without having significant side effects and toxicities can be very challenging. Some of the more interesting things in cholangiocarcinoma that have been developed recently is the ivosidenib for IDH1 mutated, which now has an FDA approval, I believe, in the second line setting, which is a desperately needed biomarker driven therapy for those patients who progress on frontline chemo IO or IO alone, depending on the performance status. Some other interesting things are MUC1 is a surface protein that's been shown to correlate with more aggressive cholangiocarcinoma, and there have now been preclinical studies looking at MUC1, both antibody drug conjugates as well as adaptive cellular therapies. So, I think we are developing more therapeutic targets. Hopefully, I think the big things that we need to think about with cholangio is, much like every other cancer, we really need to get whole exome sequencing on these patients at time of diagnosis. We really need to make sure that if we identify a driver mutation, we treat them with a targeted therapy. These are things that outside big academic medical centers still prove to be very big logistical hurdles for community oncologists, and really raising awareness around that issue is really important.
Yeah, thanks for sharing all of that. I definitely agree about sort of the need for getting better testing for different cholangiocarcinomas. I do know that patients who test for HER2 positive by blood-based sort of NGS may not necessarily be positive on central testing. So we have a lack of standard HER2 testing that I think is a challenge for diagnosing patients and identifying other lines of therapy. But I do think, as you mentioned, like finding other biomarkers, finding further lines of treatment is definitely very exciting, because before, maybe only 5% of patients with advanced disease would respond to second or third line therapies and have a very low progression free survival. But now we're seeing improvements with HER2 therapies and some of the things that you talked about. For some of our listeners who might not be as familiar with biliary tract cancers, can you just talk a little bit about the demographics and epidemiology for patients who present?
Yeah, patients typically, there seems to be a predilection for females over males with cholangiocarcinoma. There's about 10 to 12,000 cases diagnosed each year. And as I had mentioned, these patients typically present at later stages of disease. So typically beyond the point at which they can have a resection. So, more of a disease controlled palliative intense systemic therapy type of situation for, unfortunately, a lot of patients. Patients who have previous predisposing factors would include like cholelithiasis, calcifications in the gallbladder, things of that nature can predispose you, chronic inflammation in that tissue leading to the development of malignancy, all things that can contribute to the development of cholangiocarcinoma.
Yeah, that definitely all makes sense. And I know that one of the frustrating things that we see when it comes to screening is that a lot of the big cancers that we think about, like colon, breast, lung, we have screening guidelines that are set by the USPSTF. Are there any kind of universal guidelines for gallbladder biliary cancers?
Unfortunately, no. There's not current guidelines, and for screening, we don't have good screening measures as we do for even things like low dose CT scans for lung cancer and at risk populations being smokers. We don't have that for cholangiocarcinoma, unfortunately. And not dissimilar to pancreatic cancer, you see a very insidious onset of disease. Patients can be fine for a long time, and then they end up developing a pathology, like an obstructive pattern, where they ultimately kind of tip over and end up needing inpatient care or workup, and it's only at that point do we realize that they have cholangiocarcinoma and then how sick they are. So yeah, unfortunately, we don't have good imaging or blood based screening tests for catching it early.
Yeah, I definitely agree. Nothing really right now that we can universally recommend to patients to get. And sometimes people ask, should I get my gallbladder removed if I have a family history? Those things aren't really settled in the literature either. There's some exciting news. Last year, there was a study published in Lancet where a team in India actually looked at abdominal ultrasound and had a machine learning AI-based model to screen and detect gallbladder cancer. So they're actually able to get the same sensitivity as radiologists. So perhaps in the future, we might be able to kind of move the needle in that point. Are there any other points you'd like to make?
No, I think that's very interesting. You and I were talking before this, the concept of AI and machine learning to help better augment radiological readings and try and bolster our sensitivity for screening and diagnosis. Certainly, those types of avenues will hopefully bring more advancements so we can catch disease earlier. Because to be honest, catching it before someone progresses to the point beyond resection would be the goal. And you don't want to have to treat people with systemic therapies. I think the big thing that I would just reiterate is that I think it's really ingrained at large academic medical centers that whole exome sequencing really informs care, and it really does make a huge difference in opening up treatment options, not just standard of care for maybe more nuanced and rare mutations that could open up doors for targeted therapy, but also for clinical trials. So, there's lots of novel therapeutic approaches. Like to your point, there's a lot more, HER2 directed antibody drug conjugates that are in development. So testing for things like HER2 IHC expression is really important. And, there's been lots of studies published over the last 10 years that as we get into more rural centers, patients aren't getting whole exome sequencing as much. So I think just raising awareness around that and making sure that we really are sequencing our patients and opening up every treatment option, be it standard of care or trial, is the most important thing.
Thanks for sharing those insights, Dr. Hadfield. Just as I reflect on this month, just a couple of take-home points. I think one for the public, as we talked about, there's not really any universal screening guidelines for detecting gallbladder or biliary cancer. So really just as importance of having a healthy lifestyle, just avoiding smoking, trying to cut down on drinking, diet, exercise, those sorts of things. And the second is just for physicians and providers, as Dr. Hadfield alluded to, just the role of whole exome sequencing, sort of the importance of making sure patients are getting sequenced, getting genetically testing, so that we can open up different sort of lines of therapy for patients who progress on what we have right now. Thanks so much for sharing your thoughts and letting me answer those questions. And thank you all. And have a good rest of your day.
Thank you so much.